Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP examinations. We are two junior doctors based in the UK who have passed all three parts of the MRCP examinations within the last 5 years, and want you to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumb up and press the subscribe button. Now, without further ado, let's get into today's topic. Gout, which is under the rheumatology section. So, first of all, what is gout? Gout is the most common cause of an inflammatory arthritis, and it's basically due to tissue deposition of monosodium urate crystals as a result of high uric acid level. As far as its epidemiology is concerned, it's quite rare in young men below the age of 25 and also in premenopausal women. However, it is quite common in general in men compared to females, and also it's quite common with advancing age. As we discussed, it's due to an imbalance between the breakdown products of purine metabolism. And the risk factors for it are, as we said, increasing age, male sex, alcohol consumption, renal insufficiency, then that's either as a result of an acute kidney injury or an AKI, or chronic kidney disease or CKD. Family history of gout, high purine intake, and also as part of the metabolic syndrome, which is quite common in the Western world. So, in terms of causes of high uric acid, you can divide it into primary and secondary causes. Your primary causes are mostly, about 90% of them, idiopathic. However, there is about 10% of them that's secondary to enzyme deficiencies, and the most notable example of that is in Leach-Nyhan syndrome. Your secondary causes are either because of an increased production in the uric acid or due to problem with excretion of it from the kidneys. The examples of problem with overproduction of uric acid are, for example, because of myeloproliferative disease, high urine intake, extreme starvation, extreme of exercise, and psoriasis. And examples of issues with excretion of the uric acid as a secondary cause of hyperuricemia are, as we discussed earlier, renal failure, again as a result of an AKI or CKD, alcohol intake, Down syndrome, and some drugs that are very important to know for your test day. And these are cyclosporin, alcohol, nicotinic acid, thiazides, loop diuretic, ethambutol, aspirin, and pyrazinamide. And as you can see, there is quite a nice mnemonic that comes up from these, which is can't leap, which correspond with the initial letter of all of these drugs. Okay, so now let's talk about the signs and symptoms of gout. The differential for gout, remember that it can be anything that can present as an acute hot joint, such as septic arthritis. However, those specific to gout are going to be your gouty arthritis tophi, which can be around the ear or around your elbows. gouty nephropathy, which obviously you wouldn't necessarily be able to check for it as a physical sign, but it would be very important to mention, for instance, if this was a PACES exam and this was one of your station 5s, it would be very important to mention to the examiner that you would be wanting to check for renal function. And finally, patient can present as basically acute kidney stones and secondary to uric acid production. Other signs and symptoms are that it frequently affects the first MTP joint, which is also known as podagra, and it can present as a single joint or as a polyarticular gout affecting multiple joints. And then last but not least to mention is that it's a very painful condition, so thinking and talking about your pain management for the patient would be really quite important. The investigation that you would want is essentially your routine blood tests, such as full blood count, and as we discussed, the importance of renal function earlier. It's important to do uric acid level. However, it's also quite prudent to not to think that if your uric acid is not high, that means that you don't have gout, because this is what we call as a paradoxical effect, that essentially because you have a high uric acid level, it frequently gets deposited in your joint, which can lead to the attack of gout. So when you actually check the serum uric acid, you don't necessarily always in an acute attack would have a really high uric acid level. You would also want to be checking about your checking on your usual inflammatory markers such as CRP and ESR, because remember we talked about that this is basically a differential for an acute hot joint. And then really what you want for diagnosis is a synovial fluid analysis, which you can get from a joint aspirate, which it will show under polarized light microscopy negatively by refringent spindle-shaped crystals. If you have gone to the UK for your medical school, you will realize the importance of this, because this is something that test makers normally really like to ask about, because it's quite a nice and specific thing to gout, and it can be easily mistaken by another condition that we're going to be talking about and cover in future episodes. In terms of imaging, so if you image someone with a gout, you will be able to very frequently see a tophi which is surrounded by soft tissue swelling. There can be bony erosions which are usually described as punched out with an overhanging edges, or in a multiple choice question it can be described as rat bite. Importantly, joint space is usually preserved in gout, and bear in mind that X-ray can be normal even if somebody is having an acute attack of gout. Okay, so now let's talk about your management of gout. The best way to go about this would be to divide this between acute and chronic management, because they're really quite different from each other. Your acute management, the first line recommended drug is colchicine, which many of you are familiar with, and the biggest problem with it is basically GI disturbance, especially in the form of diarrhea. However, it's quite important to know that colchicine also can affect your kidney function, and it is not recommended in a patient with an eGFR of less than 10. If colchicine is not managing your patient's gout symptoms acutely, or if it's contraindicated with your patients, it would be sensible to consider other options such as NSAIDs. NSAIDs are another possibility for acute attack of gout. However, in reality, a lot of patients with gout, as we discussed earlier, will have limitation with their kidney function. And obviously, as you know, NSAIDs are nephrotoxics, which may limit your options with prescribing for those patients. Therefore, not too infrequently, we end up giving patients with acute attack of gout a short course of corticosteroids. Very rarely you can consider a drug which is an IL-1 inhibitor known as canakinumab, but in practice this is rarely used. Talking about the chronic management of gout, the recommended first-line drug is allopurinol, which many of you would be familiar with. If that is not recommended or is not managing your patients as chronic gout, you have two other options to consider. One is febuxostat and the other one is benzbromarone. Now let's talk about the other aspects of management. So bear in mind, gout is very frequent in people who've got metabolic syndrome. So advice on weight loss, advice on alcohol reduction, advice on low purine dietary intake would be really important. And normally in practice, these are achieved, as you know, through the multidisciplinary team or MDT approach, which is really a key phrase for you to know, to mention as part of any chronic disease management in your examinations. It would be quite important for you to identify and manage associated conditions that are very frequently well known with gout, such as high lipid levels, and then eventually you will need to make sure that you review the patient's drug chart. This is because some drugs, such as thiazide diuretics, for instance, can actually induce an acute attack of gout as a result of the effect that they have on your kidneys. Now let's do some questions. So question 1 is a 40-year-old obese gentleman present to his GP with an acutely swollen left ankle. He has a background of hypertension, high cholesterol and CKD stage 2. Investigation revealed a low serum uric acid level with a CRP of 45. His white cell count is normal. His GP refers him onwards to the local hospital for further investigation and joint aspiration. What does the synovial analysis show? So remember that this is relatively a young gentleman who has presented with an acute hot joint to his primary care. He has some risk factors, including hypertension and high cholesterol and CKD stage 2. The options you have is A, positively birefringent needle-shaped crystals, B, positively birefringent rhomboid crystals, C, negatively birefringent needle-shaped crystals, D, negatively birefringent rhomboid crystals, and E, hydroxyapatite crystals. So if you think about it, remember what the scenario was, what sort of phenotype was getting described in terms of your patient cohort, and as a result of that you can think that the most likely diagnosis would be gout in this gentleman. And if you recall from my slides from the beginning, basically the diagnostic finding on a joint aspirate would be your option C, which is negatively birefringent needle-shaped crystals. Next question is, which of the following drugs is not associated with an increased risk of gout? So You remember from the mnemonic that I gave you, we talked about a few drugs that are very frequently associated with an increased risk of gout and are absolutely exam favorites. The options you've got in here are ethambutol, B pyrazinamide, C aspirin, D isoniazid, or E cyclosporine. And if you remember correctly, we know that isoniazid was not part of our mnemonic. Question 3 is a 45-year-old gentleman presented to the emergency department with a 2-day history of an exquisitely tender, red and swollen left great toe. He has a background of brittle asthma. Blood tests reveal he has an acute kidney injury with an eGFR of 10. He has raised CRP and ESR. His serum uric acid is 500. What is the most appropriate choice of treatment for management of acute gout symptoms? So, this is actually quite a common scenario, especially to primary care. And this is giving you the diagnosis already. It's telling you that this is going to be gout. This gentleman has got quite a few risk factors for it. So let's talk about our options. A. Allopurinol, B. Febuxostat, C. Colchicine, D. Ibuprofen, E. Short course of oral prednisolone. So remember that you're trying to manage this gentleman's gout acutely. If you recall, we really talked about really 3 important drugs for acute management of gout, which were colchicine, NSAIDs, and steroids. So you already know that option A and B are not going to be correct, because those are the drugs that we use for chronic management. Amongst options C, D, or E, you recall that I mentioned that obviously thinking about patients' comorbidity, in particular patients' renal function, would be of particular importance. And this gentleman has got an eGFR of 10, and therefore he wouldn't be eligible for either colchicine or ibuprofen as an NSAID. And really the option that's left for you would be a short course of oral prednisolone to manage his acute hot joint, and then he will need to go on one of the options that we previously discussed as a long-term urate lowering therapy. And thanks for listening to this episode of Bite-Size MRCP. If you like the sound of what you heard today, give us a thumb up and hit the like and subscribe button below so you don't miss on our next episode. Let us know in the comments which topics you would like to hear in future, and we hope to see you in our next episode.